Hi, this is Humayun Khalili from CVI2017. I'm here with Omer Iftikhar from North Shore University Health Systems. He's the cardiology fellow. He has a very interesting case for us, treatment of SVC syndrome using an impact drug-eluting balloon.
Hi, good afternoon. Thank you for inviting me to CVI Innovations to present this interesting case. So I'll start my case. It's regarding an impact drug-coated balloon that was used to operate on benign SVC syndrome case. So the patient we know over a year now. She's a 74-year-old female with past medical history of paroxysmal atrial fibrillation, coronary artery disease with an MI in her 40s, had a LAD stent placed in. She has a long history of ischemic cardiomyopathy with an EF of around 13%. She initially presented to us with facial swelling, periorbital edema and right arm swelling that was more compared to the left, and these symptoms are happening for over a few months now. ICD was placed in and she was upgraded to a BIV ICD because her persistently reduced EF and New York Heart Association 3 and 4 symptoms. Previous ICD wires was placed at the time because she had the wires placed during early 90s and there was significant risk of perforation if we took those out. No stenosis or thrombosis was found on the venogram done at the time of the upgrade. Facial swelling started a few months after the upgrade. Initially, this was thought to be a reaction to Entresto, and her primary care physician stopped the medication and gave her some steroids without any benefit on the facial swelling or the periorbital edema. Brief physical exam, she had atrial fibrillation, she had an irregular pulse. Periorbital edema was present, right arm swelling was more compared to the left. She had mild pitting edema of the legs bilaterally. Here is the initial chest X-ray in which we see a significant number of transvenous pacemaker leads. In total, she had 5 leads placed in, and she had an epicardial pacemaker placed early on, and then it was switched to a defibrillator and then BIV pacemaker leads. Moving on, in the whole workup of this, she initially had a DVT scan of her upper extremities. That was normal. CT scan of the chest was done. The first image on top is the non-contrast coronal section that shows the pacemaker leads in the SVC and the right atrial junction. The second is a contrast one. Now there is some lead artifact, so we are not actually sure whether it was a high-grade stenosis versus a complete occlusion, and that's why we decided what to do. So because of the significant number of leads placed, and a decision was made not to put in SVC stent and just do impact drug-coated balloon treatment. Procedural details were she was loaded with Plavix, access was through the right IJ. Selective SVC venography at the time showed 100% occlusion as compared to the CT scan, which showed maybe there was some flow. Collateral circulation was found through a big intercostal versus an hemiazygous vein that was carrying the blood from the upper extremities down. Initial SVC pressure was around 26 mm of mercury. The obstruction was initially crossed by a 0.035 hydrophilic guide wire through a 4 French multipurpose catheter system. This was then exchanged over an extra support guide for 7 French 23 cm sheet. The lesion was pre and post dilated. For the pre-dilatation, a 4 mm into 6 cm Mustang balloon was used, and maximal pressure was 6 atmospheric pressure up until the balloon was completely expanded. Here is the initial venogram before the actual pre-dilatation that shows significant complete occlusion at the SVC right atrial junction, and we see on the right there's a big hemiazygous vein that's carrying all the blood towards the heart. Moving on, after the pre-dilatation, we did an impact paclitaxel eluting balloon that was positioned across the lesion. It was a 7 mm into 8 cm balloon, and it was dilated for about 5 minutes. After the dilatation, there was also a post-dilatation done with an OptiPro balloon for about 5 to 10 minutes inflation at 4 atmospheric pressures. Afterwards, a venogram was performed as well, and the SVC pressure that was initially 24 was decreased to 13 mm of mercury, and the stenosis were reduced to 50% with brisk antegrade flow. Right IJ sheath was removed and the pressure was applied to hemostasis. Not significant blood loss, less than 50 ml. This is the venogram in which we see the actual balloon that was dilated, the impact paclitaxel eluting balloon. And this is the result afterwards. Good patency, 50% of obstruction relief. There's good anterograde flow as well. In the hospital course, the patient was continued on heparin until the INR was therapeutic and she was started on Coumadin. The total length of stay in the hospital was about 3 days. As per the manufacturer's guidelines, the patients with an paclitaxel balloon needed dual antiplatelet therapy for about a month. So the decision was made to start on aspirin, Plavix and Coumadin for about a month. After the month, the Plavix was stopped, Coumadin was discontinued, aspirin was continued, and rivaroxaban was started again. And Entresto, which initially was thought to be a reason for the facial swelling, was started on an outpatient basis. There has been about a 1-year follow-up in the patient so far, and we have not seen facial swelling or periorbital edema, and the normal pacemaker function was found as well. A brief overview of the SV syndrome. It was first presented in 1757. It was initially most common in the pre-antibiotic era, where it was caused by tuberculosis and syphilitic aortic aneurysm. Malignancy these days is still the #1 cause. If we get all the malignant causes out, the benign causes, about 0.2 to 3.3% of all patients who have pacemaker or ICD placement have some sort of symptomatic SVC stenosis. If we consider just the silent thrombosis, there has been a study done in which it shows as many as 30% of all the implants have some sort of thrombosis that is not clinically evident. Most common symptom of the SVC syndrome is dyspnea. If we have an acute event that causes significant obstruction, cerebral edema can happen, and steroids have some role in it. Initial workup consists of DVT scan, as in our patient that was negative, but the definitive diagnosis consists of CT of the chest and contrast and cardiac venogram. Based on the etiology, we have number of treatment options, and they range from steroids, radiation, chemotherapy, all the way to stenting and surgery. In our case, the stenting was not performed because of significant risk of lead fracture, and if the SVC stent is placed in any of the SVC syndrome cases, there is a recurrence rate of about 0 to 40%. So now regarding the paclitaxel drug-coated balloon itself, it stabilizes the microtubules by preventing the depolarization in the cell division. Overall effect is inhibited neointimal growth and reduced thickness of the arterial wall. It has been approved for de novo and restenotic lesions in the femoral and popliteal artery lesions. But on the venous side, there have been some studies done primarily in the hemodialysis, vascular access and fistulas, in which it has shown to actually increase the number of patency years as compared to a balloon that has no drug coating on it. With this, I conclude my presentation if you have any questions, and thank you so much.
Thank you very much. Very, very interesting case about the SVC syndrome treating with drug-coated balloon. So the way you guys crossed it, was it through the IgA or was it through the femoral or
through the IgA?
Through the IgA, vertebral cross. Did he get pre-treated with anticoagulation prior to percutaneous therapy, or did they fail it, or do you guys typically go ahead and just open these because of high failure rate of anticoagulation?
So this was a good decision-making discussion that we had. So the patient had atrial fibrillation and was initially on rivaroxaban, and still developed this SVC syndrome because of stricture and all the leads being placed in. So the patient already had been on anticoagulation. So it was considered an anticoagulant failure, and then we decided we'll dilate it, but we will not put a stent in.
And the other interesting thing about this case is the usually stenting. You're absolutely right. It has high failure rate, high stent fracture rate, but it is a little challenging. I guess with the leads that are in place, it'd be hard and a little more challenging to place a stent there.
Mm-hmm. Absolutely, and we discussed with electrophysiology what the best course of action would be, and they decided we had a team approach in it and decided just to follow up clinically very closely the patient, then decide on just doing whatever comes our way.
It'd be interesting to see what happens with drug-coated balloon in the particular SVC syndrome, because from my understanding, SVC syndrome, when it occurs, a lot of the process is really fibrotic in nature, not much intimal growth or smooth muscles. It'd be interesting to see how this pans out for as you demonstrated in the hemodialysis patient and as well as in SVC syndrome, how it pans out. Well, thank you very much. This is a fantastic case. Thanks for coming to CVI, presenting it. And this is Houman Khalili from the CVI 2017.